All right, good morning. So we are now finished with muscle, and we have a lecture on the neuromuscular junction, which I hope is an easier lecture for you because we really did like 75% of this in the first year of physiology with the neuromuscular junction. So a lot of this handout will be kind of a repetition. So I'm going to go a little faster than I normally do, but we'll have hopefully time for some questions here at the end. So just for a very quick review here of the physiology of the neuromuscular junction. So our next lecture will be talking about peripheral neuropathy. Okay, so the peripheral nerves, of course, we have an action potential that continues down the nerve, and you all, based on all of you answering correctly, understand that the voltage-gated calcium channel is activated, that the influx of calcium is the important step in the fusion of these acetylcholine-containing vesicles with the presynaptic membrane, and we have release of acetylcholine. Okay, and we have these post-junctional folds here, and I'll show you a picture of where the nicotinic receptors are located. All right, so that these then are activated, okay, and we get muscle fiber depolarization, an end plate potential, and then a contraction of the muscle. Okay, so we're concerned in this lecture with three main conditions here that affect the neuromuscular junction. None of these are really that common, okay, but Myasthenia gravis and Lambert-Eaton Syndrome and Botulism are just extremely common questions on board exams, okay, but you won't see a lot of these patients when you do your month of neurology during the clerkship. Now, one thing that, if we're going to understand the difference in symptoms between Myasthenia gravis and which is a postsynaptic issue, antibodies against nicotinic receptors, versus Lambert-Eaton syndrome and botulism, is that the conditions that affect the release of acetylcholine will not only result in decreased stimulation of nicotinic receptors, that gives you weakness, all right, but you also affect areas where release of acetylcholine stimulates muscarinic receptors, right? So that is the autonomic nervous system. And so most importantly here, it's the parasympathetic system here, because remember, most of the sympathetics, it's norepinephrine, doesn't involve muscarinic receptors, just the sweat glands. All right, so if we have a problem with release of acetylcholine, we also understimulate these muscarinics that are part of the parasympathetic system. So we will see that patients, for example, with botulism or Lambert-Eaton syndrome, you affect the vagus nerve, and so you affect peristalsis, and these patients are constipated. We'll see, particularly in Lambert-Eaton syndrome, that for some reason the salivary glands are often affected, and these patients have dry mouth. So anyway, these are features that we will see with when there's a decreased release of acetylcholine, but the autonomic nervous system is never involved in Myasthenia gravis, because it only affects nicotinic receptors on muscle. So they're only allowed to have weakness, not any autonomic involvement. Okay, so again, here are the voltage-gated calcium channels, and the acetylcholine here, it's worth reviewing what happens. How do these fuse with the presynaptic membrane, and how are they released? Because that's the key in understanding botulism. Okay, so three main things here. Two of them are presynaptic, so Lambert-Eaton syndrome is here, antibodies against the voltage-gated calcium channels. Botulism impairs the snare proteins, which are critical here in this fusion process, and then Myasthenia gravis is postsynaptic. Okay, so this is where these nicotinic receptors are located on muscle. Okay, and so in Myasthenia gravis, we have antibodies here against the nicotinic receptors. Okay, so I won't go over all of this again, but remember that when calcium enters, several things happen here that result here in these vesicles fusing and then being released. So synapsin kind of binds these together, and so the calcium entering helps to just kind of break apart these clusters of acetylcholine-containing vesicles. Here we see kind of calcium sort of binding to synapsin, breaking that connection. And then we have calcium also here binds to synaptotagmin, which is embedded in the synaptic vesicle. And this seems to be the key event in causing the fusion of these 4 snare proteins. Okay, so one of them is embedded in the synaptic vesicle, synaptobrevin. Okay, and so when calcium binds to synaptotagmin, it triggers synaptobrevin to bind to syntaxin and SNAP25. So these 3, synaptobrevin, syntaxin, and SNAP25, are collectively referred to as the snare proteins. Okay, and there are 4 of them because there are actually 2 of the SNAP25s. Okay, so we'll come back to this here when we talk about botulism. Okay, so the main thing I wanted to illustrate here's the release of acetylcholine binding to nicotinic receptors. Okay, so that will cause our depolarization here of the motor end plate, or an end plate potential. And what's really unique and important about this and relevant for understanding medications to treat myasthenia is that acetylcholine is quite unique in that every other neurotransmitter is inactivated almost entirely by reuptake. And I mentioned last year that when neurotransmitters are released, the presynaptic terminals here, just like a sponge, it just kind of sucks it right back up. Okay, but in the case of acetylcholine, it's primarily inactivated by the enzyme acetylcholinesterase. Okay, so therefore, if you manipulate acetylcholinesterase, that has a profound effect. Okay, when we talk about other neurotransmitters like dopamine, yeah, there are enzymes that are involved in breaking down dopamine, but they're pretty minor. So when we interact with those and give medications to inhibit them, it's a pretty minimal effect. Okay, when you give a medication that inhibits acetylcholinesterase, it's profound. Okay, so here are the post-junctional folds, and so it's right here on the crest, the green areas here, that's where we see these nicotinic receptors. The acetylcholinesterase tends to more of it hang out down here. I don't think that's that important. Okay, but stimulation of nicotinic receptors, we get a motor end plate potential, and that's just that local depolarization. So let's start with LambertEaton Syndrome. Okay, sometimes called Myasthenic Syndrome. This is extremely rare, but again, just I would say very common. Seems like every, all the board exams I'm allowed to look at have a Lambert-Eaton question. So this is paraneoplastic. So remember the question I gave you last time of a patient with ataxia. And we said there are antibodies against the Purkinje cells in the cerebellum, and that's often due to lung cancer. Okay, so paraneoplastic means not the direct mass effect of the cancer, but it's an indirect kind of an autoimmune effect of the cancer. So there's antigenic similarity between small cell lung cancer and the voltage-gated calcium channels. Okay, so really interesting thing is that the Lambert-Eaton syndrome usually develops before the patient is known to have lung cancer. So this is usually our trigger, better look for lung cancer in this patient. Okay, so the symptoms are due to weakness, are weakness and autonomic dysfunction. So we understimulate nicotinic receptors, that's weakness. But we also don't have enough acetylcholine stimulating muscarinic receptors, and that gives us the autonomic dysfunction. So again, it's autoimmune and antibodies against voltage-gated calcium channels. So the key thing for understanding the symptoms, rather than just trying to memorize them, is just to think where are nicotinic receptors and where are muscarinic receptors. Okay, so again, 50 to 70% of patients have small cell lung cancer. There are other cancers, but that's the most important one. But just to give you an idea how rare this condition is, only 1 to 3% of patients with small cell lung cancer have Lambert-Eaton syndrome. Okay, so it's the great minority of these patients that are actually symptomatic or develop the antibodies. All right, so again, the nicotinic receptors will give a patient weakness. And I don't have a good explanation for this, but in patients with Lambert-Eaton syndrome, it tends to be mainly the legs. Okay, so classic, if we're thinking of a vignette to describe a patient with Lambert-Eaton syndrome, it would be a man who smokes, okay, because obviously it's a risk factor for lung cancer, who's getting leg weakness. Okay, in any neuromuscular junction condition, it tends to be fatiguing. So the more walking the patient does, the heavier the legs get. That would be kind of a good story for it. Okay, so we don't release acetylcholine also here in the parasympathetic system. And for, again, reasons that are not clear, it tends to be mainly the salivary glands and the GI tract that are affected in Lambert-Eaton syndrome. Okay, don't have an explanation. Why not the pupil or the bladder? But it tends to be the GI tract and the salivary glands. Okay, now there is a very unique, specific exam finding in Lambert-Eaton syndrome. And if you see it, you know, okay, this is what the patient has. So here's the thing. This is not a lower motor neuron condition. Okay, this is a neuromuscular junction condition. But it just turns out that if you knock out the voltage-gated calcium channels, that seems to be really important in developing reflexes. So when you tap on that tendon, and it's a very quick, monosynaptic to the spinal cord and back, that activates voltage-gated calcium channels very briefly. So when you knock those out, patients generally don't have reflexes, or they're difficult to get. So I know it's a little confusing. This is not a lower motor neuron condition, yet these patients usually don't have reflexes. Okay, so they have leg weakness, tends to be a bit more in proximal muscles. And like myasthenia gravis, the neuromuscular junctions that are involved in moving your eyes are affected, but only in about a third of patients. So when we come to myasthenia gravis, that's almost always how it starts. So those patients tend to have much more double vision, droopy eyelids than someone with Lambert-Eaton syndrome. All right, so here's the unique exam finding that, if you're reading this in a vignette, okay, it's Lambert-Eaton syndrome. When you very briefly ask a patient to exert a muscle in Lambert-Eaton syndrome, that brief exertion actually overcomes the blockage at the voltage-gated calcium channels for just a few seconds. Okay, so what happens then is, usually what's most obvious on exam is you can't get reflexes, and then you ask the patient, like if you're checking biceps, okay, make a muscle really hard, and then you check it again, and all of a sudden it returns for a few seconds, and then it goes away. Okay, there's really nothing else that does that. Or very briefly after activation, the muscle may get briefly stronger, but that's just very short. Okay, this is more of an exam finding. Okay, these patients have fatiguing weakness. They're not going to tell you when I exercise I get stronger because the duration is so short. Okay, but they will complain of fatiguing weakness. So this so-called post-exercise facilitation really describes just something you can do on your examination to really suggest the diagnosis. Okay, so again, ocular and bulbar. Bulbar refers to talking and swallowing. These are symptoms that are very dramatic in myasthenia gravis, but overall, can happen in up to half of patients with Lambert-Eaton syndrome, but it's mainly the leg weakness that tends to be most prominent. Okay, so let me just, this was a patient, I only have a video of this from 20 years ago, so you'll see what I look like with hair here. I have this on I just haven't been able to record a good one since. But this is a patient with Lambert-Eaton syndrome that I saw a long time ago. And, he sometimes will jump when I tap his reflexes. Some patients will do that. They'll anticipate it, and they'll want to move. But his reflexes are really hard to get. Maybe I can get a trace reflex there. But except for maybe a trace right patellar, I really can't get any reflexes. They're absent in the arms. Brachioradialis, can't get it. Okay, so now we're going to have him activate. Okay, and I do this repeatedly. And now you just have a few seconds. You have to be fast. And now he has, that reflex is now very easy to get. Let me check it on the other side. Have him activate his quads. There it is. Okay, so that's the post-exercise facilitation. As we keep checking, again, it doesn't last long. Now it's gone. Okay, so if you think about Lambert-Eaton syndrome, that's what you want to do on examination. Okay, so we mentioned that. So diagnosis, fortunately, this is an easy diagnosis to make if you thought of it. The antibodies against the voltage-gated calcium channels are present in most patients, and they're very sensitive and specific, so it's usually an easy diagnosis to make. There are also things we can do on EMG, which I think we're going to talk about next Tuesday, I believe. But I'll just tell you now, because you need to know it, even though you're not going to understand it right now. You get what's called an incremental response, which is kind of electrically the same thing that I just showed you in the video. Okay, we're able to electrically, briefly stimulate or overcome that blockage at the voltage-gated calcium channels, and it results in something very unusual, which looks like this. Okay, again, don't worry about understanding this. I will explain it next Tuesday. But that incremental response is what we see electrically, and that's the correlation of that post-exercise facilitation. Okay, so when you diagnose someone with Lambert-Eaton syndrome, and you remember this is cancer-related, especially lung cancer, you go searching for cancer, but the Lambert-Eaton syndrome may predate the identification of the cancer for some time. Okay, so we just have to really be on top of it, especially if a smoker. We're going to be doing, chest CTs, maybe a PET scan to just detect it at its very earliest stage. Sorry, you probably don't know about PET scans yet, but when we get to brain tumors, we'll talk about PET scans. Okay, so again, the Lambert-Eaton syndrome often precedes the cancer for some time. Now, there's a medication which really probably the first medication here that you would commonly be asked on a board exam, called 3,4-diaminopyridine. Okay, and I think they like to ask about this because the mechanism is well known and can be explained, and why it helps patients with Lambert-Eaton syndrome. So here's a normal neuromuscular junction here. So this is an action potential traveling down a nerve. Here's potassium efflux. Here's calcium entering, okay, causing release of acetylcholine, stimulating nicotinic receptors. All right, so here's Lambert-Eaton syndrome, where we have antibodies attaching to the voltage-gated calcium channels. Okay, and so as we've explained, then you're going to have less release of acetylcholine. So the effect of this medication, 3,4-diaminopyridine, its action is to block the potassium channels. And the effect of that is actually to prolong the duration of the action potential. So you prolong the duration of the action potential, you can then, so here we see kind of more action potential here, and that actually helps a little bit to overcome the effect of the antibody against the voltage-gated calcium channel. You get a little more calcium into the presynaptic terminal, and so here we see more release of acetylcholine, not normal, but it's more than in the pathologic state. Okay, so 3,4-diaminopyridine can help with the symptoms of weakness in Lambert-Eaton. Yeah. The main risk of 3,4-diaminopyridine is it can cause seizures. So, and interestingly, I have one patient with Lambert-Eaton syndrome who also has epilepsy. And so that's kind of a debate, well, should we put him on this medication that can cause seizures? So that is much more common of a risk. Okay, so contrast Lambert-Eaton then with Myasthenia gravis. Again, postsynaptic, so there's no problem with release of acetylcholine and myasthenia gravis. Normal presynaptic release. Everything with the snare proteins, voltage channel is fine. So we just have antibodies against the nicotinic receptors. Okay, so that's just a key point to remember. Okay, so myasthenia, so these are all autoimmune, both are autoimmune conditions. Myasthenia is associated with other autoimmune diseases, though, not cancer. And so in the case of myasthenia, especially hyperthyroidism. So when we've diagnosed someone with having myasthenia gravis, we always check and make sure that they're not also hyperthyroid, because you want to treat that if they are. The pathophysiology of myasthenia seems to be related to the thymus gland. Okay, so 8 to 10% of patients with myasthenia gravis have a thymoma, but if you take the thymus gland out in someone with myasthenia and you look at it, pathologically, there's usually hyperplasia and abnormalities, not necessarily tumor, but it's usually abnormal. So there are these kind of muscle-like cells in the thymus gland that look a little bit like muscle. So there's some antigenic similarity, and so in young individuals, we recommend taking the thymus gland out once myasthenia is diagnosed. Okay, so young individuals that get myasthenia are more likely to be women. Over the age of 40, it's more common in men. Okay, and so another look here of what happens here in myasthenia gravis. So here are these nicotinic receptors, and so here we have some antibodies here, and notice that the antibodies actually damage the nicotinic receptors, and not shown here, they will actually then be taken back up here, destroyed really. So you reduce the number of nicotinic receptors. It doesn't destroy all of them though, so there are still available nicotinic receptors that are there, and so what we're trying to do in treatment is to stimulate the ones that are left that are still available to bind to acetylcholine. Okay, so the presentation of myasthenia, oftentimes patients have seen multiple doctors because people just don't think about myasthenia. It's known as the great mimicker. It can present in a wide variety of different ways. Okay, so symptoms tend to come and go. That's the other problem. You come in to see a doctor for something, and well, I'm not having it right now. There's nothing to see. So that can make it challenging. And so it's often a long time to make the diagnosis. But one thing that would suggest it historically is if the symptoms occur with fatigue. Okay, so again, usually starts with the eyes. So if the patient is normal most of the day, but then tells you, 4 o'clock in the afternoon, 5 o'clock, long day at work, driving home, and that's when I get double vision. Okay, that would be a good story for myasthenia gravis, a kind of a fatigue or working out. I saw a lady years ago who was a deep sea diver. Okay, and after a really strenuous deep sea dive, that's when she'd have her double vision. So again, this is not a lower motor neuron or an upper motor neuron problem, doesn't affect sensory nerves, so all of that is normal in patients with myasthenia. Okay, and so fatiguing weakness, again, is the hallmark of a neuromuscular junction disease. Myasthenia is our classic example of that. So here's the mechanism for fatiguing weakness, which I think I went over briefly in the first year. When you exert yourself, just holding your arm up for a period of time, the actual release of acetylcholine drops a little bit with exertion. Okay, now we're not symptomatic of that though, because the drop of acetylcholine is still far above the threshold that is necessary to fully stimulate neuromuscular junctions on muscle, so we get normal muscle action potential, normal strength, even though during exertion there is a continued drop of acetylcholine. That's the safety factor. Okay, these neuromuscular junctions, much more is released than is necessary, so there's no weakness, no fatiguing weakness. When, however, you knock out a certain number of nicotinic receptors, you are reducing the safety factor. Okay, and so now what is going on here? We're having this patient exert for a long period of time. Maybe we're having the patient hold their arms up or pushing down. Come on, give me good effort. Okay, so this drop here of release of acetylcholine is normal. Okay, this is just prolonged exertion. This is what would happen in any of us in that situation. So this is not the abnormality. The abnormality is that, look at the great reduction here in the safety factor. So now that normal drop in the release of acetylcholine, we're now falling below at certain times the threshold for full muscle fiber activation. Okay, so we get clinical weakness with fatigue. Okay, and it has to do with less nicotinic receptors available, lower safety factor, and so patients have fatiguing weakness. So realizing that, your exam needs to be tailored to try to bring this out so you can then observe the weakness. So we do a different neurologic examination if we're thinking about myasthenia gravis, which I'll explain. Okay, so clinical features usually starts in the eyes, okay, in 2/3 of patients. So again, it's the great mimicker. It can present. I saw a patient that presented with weakness playing the piano. Okay, and myasthenia didn't enter my mind because I'm just thinking, oh, that should start with double vision. So in 2/3 of the cases it does. So generally the most common initial complaint would be a droopy eyelid that comes and goes, or double vision, or both that will come and go. Okay, and so this is kind of what a patient will look like. Now this patient may come in looking normal. Okay, and so what you want to do then on exam is to fatigue those neuromuscular junctions. So we will have the patient look up at the ceiling. Okay, and you have to be patient, like 2 minutes, looking up at the ceiling, and you will see what's called the curtain sign, where the eyelid will gradually come down. Okay, interestingly, you can facilitate this by lifting up the other eyelid. That tends to bring out more of the ptosis in the opposite eye. Okay, or if a patient has double vision, you may have the patient look back and forth, and you keep doing this, and then all of a sudden you notice one eye is not moving very much. Okay, you fatigue the neuromuscular junction, and then the patient will complain of double vision. Okay, so that's the initial complaint, and it's fatiguing, so you bring it out on examination. Okay, and so we have to look for that fatiguing weakness as we do our exam. So remember the question I asked you, I think last week, that the pupil, for constriction of the pupil, it's muscarinic receptors. So we're never going to have, a dilated pupil or anything like that in myasthenia gravis. Pupil is normal. Okay, 15% of patients have what's called pure ocular myasthenia gravis, which means for the entire course of their illness, it's only the eyes. It never affects anything else. Okay. Now, the next most common presentation involves the neuromuscular junctions excuse me, for talking and swallowing. So patients have episodic slurred speech and difficulty swallowing. So I've seen patients, there's one video on the canvas that I'm not going to show you, a patient that has dysarthria, and oftentimes that will come out as they're talking for 20 minutes. They're describing their history, and then you're noticing the words are becoming slurred. Okay, so that's, fatiguing those neuromuscular junctions. Or patients will tell you chewing food. They start out fine, but after a while, especially if it's something really tough like meat, they just kind of get tired of chewing. Okay, that would be fatiguing weakness. Bulbar symptoms of dysarthria and dysphagia usually go along with neck flexor weakness. So that's a muscle we don't routinely check in neurology. Remember, it's weak in Duchenne's muscular dystrophy, but that's a muscle that tends to be weak in myasthenia gravis as well. So we'll have a patient bend their chin down to their chest, and you'll push forward, okay, and you'll give kind of prolonged effort to see if you can fatigue it and overcome the muscle. Some patients can have facial weakness, because of course those are all neuromuscular junctions involved in smiling, raising your eyebrows. What's really potentially serious, called myasthenic crisis, is where the neuromuscular junctions involved in breathing are affected. So if you have a patient with myasthenia who's short of breath, that's an emergency. That patient needs to come into the emergency room, likely needs to be admitted. Myasthenic crisis is highly correlated with bulbar symptoms of dysarthria and dysphagia. So when we have someone with myasthenia who's choking on their food, who's having slurred speech. We're especially concerned about that patient, that they may have the respiratory involvement. Okay, and so there are a number of things. Myasthenia gravis used to be grave. That's where we get gravis from. Modern treatment just works great for these patients, but this is the most common cause of death in myasthenia, is respiratory failure, and it's preventable. All right, so the muscles do tend to be the more proximal muscles that are weak, okay, but usually we can distinguish this from a muscle disease because of the profound fatiguing component. Okay, so someone with myasthenia, maybe they initially hold their arms up pretty good, so you're checking deltoids, a proximal muscle. But as you keep pushing, every time it gets weaker and weaker, and then finally after you've done it 5 or 6 times, you may just be able to take 2 fingers and just gently, push the muscle down, where initially it seemed pretty strong. Okay, so the fatiguing component should help distinguish it from something like a myopathy. But again, a great mimicker, my patient weakness playing the piano. So it can do all kinds of things. It can make it hard to diagnose. Okay, so exercise intolerance, again, if you've got weakness of these muscles, just like walking upstairs is difficult for a patient with myasthenia. You're walking up 3 flights of stairs. I mean, you've really fatigued those neuromuscular junctions at that point, and patients will just say their legs feel very heavy. So muscle testing should include sustained resistance, which we don't do routinely, but if you're thinking about myasthenia, you have to. All right, so how do you diagnose myasthenia gravis? This is a favorite board question, but we actually don't do this that much anymore. It's spectacular. You give a medication IV called edrophonium, otherwise known as tensilon, so it's called the tensilon test, and this is a potent inhibitor of acetylcholinesterase. So very briefly and dramatically, since acetylcholine is mainly inactivated by this enzyme, you have much more acetylcholine available. Okay, and so all of those nicotinic receptors that are unbound are now flooded with acetylcholine. And so for a brief period of time, the patient gets dramatically better. Okay, so it's just a bedside way of confirming the diagnosis. The reason that we don't do tensilon much anymore is the blood test is so good for myasthenia. We have other ways of making the diagnosis. And just think, okay, if we're going to knock out acetylcholinesterase, now we also have a lot of acetylcholine stimulating muscarinic receptors, and those are on the heart, right, the vagus nerve. And so, you have to do cardiac monitoring, and there is some potential risk of doing the tensilon test. So I would say most neurologists, I was at a meeting recently and they asked who's done a tensilon test in the last 5 years, and I think 3 hands went up in a big audience. You still need to know about it because, I don't know, still will show up on boards. But if you give this medication, oftentimes it'll cause fasciculations, those little muscle twitches, and that's just from too much nicotinic stimulation. And if you overstimulate muscarinic receptors, then patients may sweat during the test, and they may have some nausea. Okay, I may have told you during the first year that this can be so profound. Like patients come in, they can't open their eyes, you lift up their eyelids, they can't move their eyes, and you give the edrophonium, and it seems like a miracle. For a few minutes, they're moving their eyes and doing just fine. So just remember to tell patients this is a test. It will help to confirm the diagnosis, but the one case I saw where the family thought that I had healed the patient, and then it was very depressing when the eyes came back down and things went back to their baseline. Okay, so there are other things we can do. Let me come back to this when we talk about EMG, but remember I said in Lambert-Eaton Syndrome they get this incremental response. In myasthenia gravis they get a decremental response. This is the electrical way that we can confirm the diagnosis, but let me explain that next week. We have a great antibody test in myasthenia, so it's positive 85% of the time. It's pretty good. But if someone has ocular myasthenia gravis, it's only helpful 50% of the time. This is just used to confirm the diagnosis. So the antibody levels do not correlate with having a bad disease or a mild case, and so we don't follow antibody levels. There's no reason to. It just is used initially to make the diagnosis. All right, so again, I'm not going to explain this now. We will next week. Here is electrically what a normal neuromuscular junction looks like. Okay, we get normal muscle action potential every time, and in myasthenia we get this decremental response. Okay, again, this is just electrically what you're seeing on examination, where the muscles fatigue and they get weaker. So another great bedside test to do, it's called the ice pack test, where you have a patient maybe that has ptosis, and you just put ice on the eye for a minute or two, and ice actually partially inactivates acetylcholinesterase. Okay, it's not as dramatic as edrophonium, but if you take the ice pack off and now the eyelid is up, well, that wouldn't just happen from ptosis from any other cause. So the ice pack test can be just a simple bedside thing to do. So when we've diagnosed myasthenia, remember that 8 to 10% of patients can have a thymoma, so we always do a chest CT to look for a thymoma. So that's important. And in younger individuals, and young is kind of loosely defined here as 55, it's recommended they have a thymectomy. This is a big deal. You have to crack the chest, and the thymus gland is often spread out kind of diffusely under the sternum. So it's not a small thing. That's why over the age of 60, you probably wouldn't. But there's now really good evidence-based studies that show that patients do better if they've had their thymus gland removed over the course of the illness. Okay, now medications. So of all medications we've talked about, which is not too many, this would be the very high yield for a board exam. Pyridostigmine. Okay, and I should have put this the other way around. You need to know the generics. So for now, pyridostigmine. When you get into the third year, we'll talk about mestinon. Okay, but pyridostigmine, this is an oral acetylcholinesterase inhibitor. So it's just like edrophonium, but it lasts a long time. So a patient could take this maybe 3 times a day. And so that would cause their acetylcholine levels to be elevated during that period of time. And this is almost always our initial treatment. And in many cases, it's really satisfying because you start a patient on this, they do great, and that's all you need to do. Just keep them on the pyridostigmine medication. Now again, so we're elevating acetylcholine. That's good at neuromuscular junctions, but the side effects then tend to be on the autonomic nervous system. So you overstimulate muscarinic receptors on the GI tract, stomach cramps. That's the most common side effect. And kind of along with that would go diarrhea. Okay, so that's often what limits how high you can go with the medication. Okay, and sometimes if we overdo it at neuromuscular junctions, patients will have fasciculations. Okay, so little twitches in the eyelid or other locations can be seen. That's usually not very annoying to the patient. They're just happy to be stronger. Okay, so with any kind of an autoimmune condition, as we're going to see repeatedly in neurology, steroids are helpful. Okay, so steroids work well, but now you know all the long list of potential side effects. So we don't usually go to this right away. Okay, just if maybe the patient's not responding to pyridostigmine, we might just try this for a brief period of time to try to get things turned around. So this can really help. Beware of long-term side effects. And I have in your handout that there's kind of a unique thing with myasthenia. When we use steroids, we always start with a high dose and taper the patient down. In myasthenia, a good number of patients, if you start with a high dose, will actually get worse initially. And remember, what you're worried about in myasthenia is the respiratory involvement, the myasthenic crisis. So in myasthenia, we do something kind of unusual. We start with a low dose of steroids and work our way up. And that reduces that likelihood of a patient having an exacerbation. Okay, we talked about this medication, an immunosuppressant, azathioprine, in the inflammatory myopathies. And so this works quite well, but I mentioned these take a long time to kick in, up to a year. But someone has myasthenia gravis, this is a lifelong illness generally. Okay, so you're shooting for the long term, for thymectomy, azathioprine. These are things that will impact the disease over the course of many years. And as I mentioned with the inflammatory myopathies, these immunosuppressants, they limit how much steroids you need to use. So that's good. You get the steroid sparing effect. Okay, and likewise with the inflammatory myopathies, I said IVIG. It also works for Myasthenia gravis. And we can also do something called plasmapheresis. This is where this big machine, and the patient's plasma is filtered through this machine. You filter off these antibodies that are responsible for the symptoms. So these are both heavy-duty, very expensive treatments, but this is what you would do for a patient in myasthenic crisis. So that patient who's, you don't want to put on an intubator, you want to do something right away. This would be our big gun treatment for that kind of a situation. Okay, and sometimes if we've exhausted everything else, then we will again try to use these to turn things around. Now when a patient has thymectomy, as I mentioned, that's not a small little procedure. We will often give something like IVIG prior to the surgery just so that they're as strong as possible coming out of anesthesia. They're going to be able to come off the ventilator, faster. So we'll often give that as kind of a pre-treatment prior to the surgery. Okay, so I have a video I hope to have time to show, but I want to make sure we get through here botulism, so let me just save that for the end. All right, so botulism, is caused by the exotoxin, and you will learn in infectious disease. I'm not going to go over this, all the details about the bacteria, so I'll save that for your microbiology. But this is really ubiquitous in fruits and vegetables, in the ground. Okay, so under certain conditions, and this tends to be mainly low oxygen, kind of like an underlying infection. We'll talk about in heroin users, low acidity, kind of a warm temperature. Think of canned goods, sitting in kind of a warm closet. That's when things tend to develop. So botulism is found in contaminated soil or foods, and so you get this either through ingestion or from some sort of a wound infection. So what we see just a lot in this area. I mean, so many cases that at first it was exciting, but after a while, when you've seen your 15th case of a heroin user developing botulism, a little bit of the novelty of it wears off. But in Southern California, you see a lot of this from black tar heroin from Mexico. Okay, and maybe I told you this, it was maybe a year ago that there was a 15-year-old pregnant woman who used heroin who came in to the county hospital here, I think the youngest pregnant person, individual who had botulism. And so that was from black tar heroin use. Infantile botulism is pretty uncommon, but can happen from ingestion of honey, so that's why it's recommended not to use, that infants shouldn't use honey up to a certain age. It's not clearly defined, maybe 12 months or so. Because of the immaturity of the GI tract, they'd be a little more prone to botulism, and improperly homed canned foods. So this is always like if you have a vignette where a whole family is brought to the hospital after a meal. Well, that's probably going to be botulism, okay, especially if they have the right exam findings. Okay, so let me show you a picture here of botulinum toxin. So it binds to the axon terminals, and the disruption here is with the snare proteins. So the toxin actually has a heavy and a light chain. The heavy part of it seems to be important mainly for introducing it into the presynaptic terminal. It's the light chain right here that is responsible for cleaving the snare proteins. Okay, so what's happening here is these synaptic vesicles don't fuse, and we then don't stimulate nicotinic receptors. Okay, but that's also the mechanism for releasing acetylcholine for the parasympathetic system, the muscarinic receptors. So again, we understimulate those as well. So the symptoms come on quite dramatically. This is a lot different than Myasthenia Lambert-Eaton Syndrome. It comes on over a long period of time. You get botulism, you're in the emergency room right away. Okay, so generalized weakness is the presentation. Okay, and this takes a long time because entirely new neuromuscular junctions have to be formed. So these patients are pretty weak for often several weeks in the hospital, quite ill, and it takes a long time to recover. So fortunately, we don't have any central nervous system effect because it can't cross the blood-brain barrier. So after exposure, if it's something that's ingested, there's often a lot of nausea, vomiting, diarrhea. Patients just feel like they're getting the flu. Okay, but then they start to get weak. And botulism, classically, it's a descending paralysis. So it starts with the eyes and then works its way down to the legs. So patients initially complain of double vision, droopy eyelids, and then they can't talk and swallow, and then they're getting weak in their arms and legs. Okay, and again, this can be quite dramatic, and our biggest concern is definitely neuromuscular junctions involved in breathing are affected, so respiratory failure is the main thing here that would be a cause of death. Okay, so we don't stimulate muscarinic receptors. The most important one for you to know for two reasons. One, it's just such a great exam finding, and then the other, it should just jump out at you on a board vignette, is that we lose the acetylcholine that's continually stimulating the pupil. Okay, and so if you lose that, now the sympathetics, which remember dilate the pupil, are overactive. So these patients have big, fixed dilated pupils. Okay, usually fixed dilated pupils is something we see in coma or brain death. I mean, that's a really bad sign. But these patients are awake and alert, but they have huge dilated pupils. So mydriasis here would be kind of a classic finding. They could have a dry mouth from understimulation of muscarinics. They could have constipation from understimulation of muscarinics on the GI tract. Okay, so the presentation of rapidly progressive diffuse weakness, ocular and bulbar, dilated pupils, in a nutshell, that's what you want to think of in botulism. So here's a patient who has ptosis. You lift up the eyelids, and there are the big pupils. Okay, and this patient probably, you have them try to follow your finger, and they can't because of the neuromuscular junctions there are just knocked out. Okay, do you remember in Lambert-Eaton Syndrome, I showed you a picture, and we get this incremental response? Okay, you get the same thing in botulism. Okay, both presynaptic conditions, you get this incremental response. Okay, again, I know that doesn't make sense now, but it will next week. You can measure, if it's GI, you can measure the Clostridium botulinum in the stool. If it's from heroin use, you just look for the heroin injection sites, and you may be able to culture it from the wound. There's a toxin assay that you can do in the stool and the serum. Okay, so we have several ways of confirming the diagnosis. Again, the main concern is respiratory failure. So many of these patients, you may just need to put on a ventilator, until they're getting better and stronger and can breathe on their own. If it's from GI ingestion, we'll do a gastric lavage just to try to empty the GI contents. And obviously, if they have a wound, you're going to clean the wounds, and we'll typically give a patient penicillin, which can help. And there is an antitoxin, kind of an antidote to this. So we'll give that to kind of block the effects of botulinum toxin. Okay, so again, the antitoxin, penicillin can help mainly with wound infection, and then just supportive care. These patients are going to do well. Okay, they just need a little bit of time to form new neuromuscular junctions. Okay, this will be the last slide here, but when we give botulinum toxin, which we do a lot, for it's so helpful for so many neurologic conditions, you want to remember the same mechanism. Okay, we're knocking out snare proteins. And so what we will typically then use botulinum toxin for conditions like dystonia, which we will talk about in a couple of months. Dystonias often happen of neck muscles, where they're overactive and the neck will twist and turn in certain directions. And so we inject botulinum toxin into these muscles, and it's dramatically effective. Okay, so you're reducing acetylcholine, and that helps the muscle to relax. But interestingly, we can do this for other conditions. Patients that have excessive drooling. Okay, this is actually a big problem for certain patients. You can inject them into the salivary glands, and now you're not releasing as much acetylcholine to stimulate muscarinic receptors, and so the mouth dries up. Hyperhidrosis. There was a student years ago who had sweaty palms. This is more than 10 years ago, so I think I can tell this story. And he was embarrassed going on interviews because he didn't want to shake hands, and he has a drippy, hand. And so you can inject botulinum toxin into the hand, dries up, because again, those sweat glands are acetylcholine, and so you get a dry hand. Now, this lasts for 3 months. So when we're treating these conditions, they have a good benefit for 3 months, but then it wears off and they need to have the injection again. Okay, so I will show you the videos I was hoping to show maybe at the beginning of the next lecture. All right, have a good day.